Hello, everybody. Again, Dr. Alyu, we're here. Terry's partner in A&T lectures, as well as professor at Rutgers. And again, I do a bunch of other things, edit textbooks. I teach respiratory for County College Morris, and I still work in the ICU, the adult ICU, routinely. And right now, we're going to talk a little bit about some case studies in pulmonary function testing to build on the ensemble of other material that we've covered in other lectures related to pulmonary function testing. So let's take a look at the first case here. So in this first case, we have a 73-year-old male presents with progressive dyspnea on exertion over the past year. He reports a dry cough, no wheezes, no sputum production, nor fevers or hemoptysis. He's a lifelong non-smoker, worked as a lawyer until retiring 3 years ago. He likes to hunt and fish in his leisure time. So looking at his pulmonary function tests. Okay, so just to give a little bit of specificity, his vital capacity, the actual was 1.57. Predicted was considerably more than that, roughly 3 times that at 4.46 was predicted. So he's 35% predicted for his forced vital capacity. His FEV1, the actual is 1.28. The predicted was also about 3 times that at 3.39, and he's at about 38% predicted. The FEV1 to forced vital capacity, if you think back, that the normal, you would expect about 75%, 75 to 80% of the forced vital capacity to be able to be exhaled in that first second. Okay, so the actual is 82. It's a little faster. The predicted is 76, and again, normal predicted would be around 75%, something along those lines for most of us. The functional residual capacity 1.73, and the predicted is 3.80 for 45% predicted. Residual volume is 1.12. The predicted is 2.59, and the percent predicted is 43%. Let's look at what's going on here so far. We're going to continue on, but what we have is we have both our, if you will, flows and our volumes significantly decreased. So the residual volume is again 43%. Total lung capacity, so these are related. You have residual volume. In all likelihood, the total lung capacity is also reduced because the residual volume is down. Okay, so total lung capacity is 2.70. You would expect that for an average, male total lung capacity is probably around 6 for a male and around 5 for a female. In this particular case, again, 6.45, and this individual is at 42% predicted. And then you have residual volume relative to total lung capacity. You actually see, pardon me, that's pretty well online with what's predicted. Okay, what's predicted there. DLCO, so we covered that in other presentations, where you have 5.06, and then you actually have the an actual predicted of 31.64, so significantly decreased diffusing capacity. So let's take a look at what we think this may actually mean here. So before we got there, we're actually looking at the shape of, if you will, the flow volume loop. So just, you guys have probably worked with flow volume loops quite a bit, but you have the part that's, if you will, south of the border, that's below that horizontal line. That's actually, looking at it, it looks relatively normal. What is not normal about this, okay, is that it's like a spiked pattern. So it's, if you will, compressed. That when you look at exhalation, which is the top part of this, okay, by the way, the dotted line is really kind of, it's showing what the normal, about what the normal would be expected, okay. So what you actually have is your volumes are a little bit decreased, okay, but your flows, when you look about that time, okay, is significantly so. And I will tell you, for If any of you guys have studied, flow volume loops and things along those lines, this is certainly looking like a restrictive condition where it's actually compressed and somewhat spiked. Patient has reduced FEV1. So let's kind of look at all of this together here. They have a reduced FEV1 and forced vital capacity with a preserved FEV1 to forced vital capacity ratio. Okay. So what we're going to say is FEV1 to forced vital capacity is much less effort dependent than things like peak flow. So it really looks like that element of flow is relatively normal. Okay, that element. So the total lung capacity is reduced. The patient therefore seems to have a restrictive disorder or defect. Okay. The flow volume loop is also characteristic appearance of a restrictive process. Tall, though not necessarily normal tall, but relatively approaching normalcy. Okay. Narrow, but it has a short expiratory phase. And if you actually think of what's going on, if someone has a stiffer lung, if they have a stiffer lung and or a stiffer thorax, that they're, if you will, the work of breathing, the inhalation part is hard, but what happens is the thorax and or the lung want to return, it's stiff, and wants to return more to its resting phase. Okay, so it's short, but it snaps back quickly, So hence you get that tall, narrow appearance. Based on the fact that total lung capacity is 50% predicted or below 50% predicted, this would be classified as a severe restrictive defect. What's also very significant, and in this case warranted to get, it's good that they got it, is his DLCO. It's also markedly reduced, indicating or suggesting that he has a reduced alveolar capillary interface for gas exchange, suggesting that the cause of a restrictive process lies in the lung parenchyma. So this interpretation is coming up with the fact that it's restrictive is easy. Okay, coming up with the fact that it's both restrictive and its DLCO is markedly reduced is also fairly obvious. Okay, what they're saying with the lung parenchyma is it's probably a kind of a pulmonary fibrosis, interstitial lung disease type of condition. So don't be, not that you're confused, but don't be thrown off by lung parenchyma. They're talking about really the connective tissue is really what they're talking about, the periphery and the connective tissue within the lung itself. And they're really saying that, it's kind of a way of saying lung parenchyma would be a way of saying that it's a pulmonary fibrosis, interstitial lung disease type of a defect. And again, looking at a little more with the pulmonary, more diagnosis. Now, I will tell you that a chest X-ray is probably not a good way to, certainly alone, you'd never make a diagnosis of pulmonary fibrosis or idiopathic pulmonary fibrosis with a chest X-ray. Okay, you're much more apt to do it with, or to receive the aid of, let's say, a chest CT scan. That will give you much more granularity. It'll give you much more resolution of the tissue and that sort of thing. Okay. But again, this particular one is showing you markings, particularly the lateral lung X-ray is really showing you that there's a lot of opacity there. It's very diffuse. So could those opacities be caused by things other than idiopathic pulmonary fibrosis? Yeah, they could. But what we have now is pulmonary function testing as well. Okay. And we have diffusing capacity on top of that, all right? And we also have the patient, it was a lifelong non-smoker, okay? So they really are not at risk for high risk for masses, anything along those lines. They're not at high risk for COPD. Certainly the patient could have gotten, pneumonia or something along those lines, but that's not what's going on here. They're not really saying he's running a temperature, not coughing up stuff, whatever. So really looking at all of the moving parts, there's a high index of suspicion for idiopathic pulmonary fibrosis. Again, idiopathic is, we don't know the cause of it. So guess what? The most common cause of pulmonary fibrosis is idiopathic. We don't know the cause of it. Exercise stress test. So we have an individual who's 5'10", 310 pounds, 47-year-old male, been on disability from work from a meat packing plant due to exertional dyspnea for 2 years. He and his doctor are claiming that the dyspnea is due to breathing hazardous fumes at work. I guess, that the meat or the fat in the meat or the bone marrow or the bone meal or something. It just, was causing some issue there. The firm representing the workman's comp insurance company has ordered a cardiopulmonary stress test to help determine the cause of the dyspnea. Okay, so this guy is about my height. I weigh, as I said, 180 pounds, give or take, 185 pounds. And he's 300 and change, 300, whatever pounds there. So we're going to put him on a treadmill or exercise bike. Probably, by the way, what we're going to probably do, if this test is actually going to be done, is he's not going to be on a treadmill. He's probably going to be on an exercise bike. So let's look at some of the variables here. Okay. And this, we give a series of presentations on this, but this depiction here is really to show some of the variables that are actually measured on the cardiopulmonary exercise stress test. So the variable, again, SaO2 and PaO2 results 96%, pardon me, for the saturation, 88% torr, for the blood gas, if you will, and the PO2. Reference range are listed here, and the clinical significance. So triangulating the signal, decrease in interstitial lung disease, but here's the deal. They're normal. Okay, just to be clear on this. Okay, SaO2, PaO2 are normal. Heart failure, obesity, deconditioning. Okay. The anaerobic threshold listed here. Okay, reference range. So anaerobic threshold is normal, just to be clear. So I'm cutting to the chase here, just to kind of, again, keep it from being excessively noisy here. So vascular disease, deconditioning, heart failure, COPD can all cause it to be abnormal. In this case, not applicable. Dead space to tidal volume, pardon me, the reference range, you would expect it to be less than around 28%. The books vary. Some of the books say as high as 30, some of them say, 20 to 25, but certainly in that, kind of 20 to 30 range would be, a kind of a happy medium for the different sources that you have there. The results for him are 22. Okay, 22% or 0.22. And again, it would be increase in heart failure, COPD, interstitial lung disease, pulmonary vascular disease, normal in obesity and deconditioning. I'm just seeing a pattern here. You just go to this patient's results so far are normal. Now, I will tell you that this individual could not complete the whole test, but completed enough of it where we can extract these results. Then the minute ventilation to CO2 production at the anaerobic threshold. Okay, what was actually obtained was 25, and less than 34 would be deemed normal. Okay, so again, increased heart failure, COPD, interstitial lung disease, pulmonary vascular disease. His is normal in obesity and deconditioned. Oxygen pulse, so oxygen uptake with each heartbeat, if you will. Results are 88%, greater than 80%. It's reference range. So you're seeing kind of a trend here. Okay, so we're going and we're trying to triangulate the signal and saying, okay, so if it's, increasing this one and decreasing this one and increasing, but what we're seeing here is these values are normal. Okay, and it's just, when I say in one respect, it's perplexing. Okay, so interpretation. This patient's key cardiopulmonary stress testing results seem relatively normal, though the test was ended prematurely due to dyspnea. Okay, enough to get the results, but again, dyspnea. However, enough of the test could be conducted to ascertain some key variables, namely those that were listed. All of the key variables are within normal ranges, suggesting that the patient has neither a respiratory nor a cardiac limitation to exercise. This, combined with the patient's severe morbid obesity, and occupational history, which is not often associated with pulmonary nor cardiac disease, suggests that the dyspnea maybe due to the morbid obesity, perhaps malingering, and not due to occupational exposure. Okay. Now, let me say this. We're not going to make this, or the experts aren't going to make this determination based on this information alone. Okay. But it's going to be some key information. Okay. And I will tell you, if the case, the workman's comp case, ever makes it to court, it will be the expert physician who's interpreting these results, and it will be critical, not just testimony based on, if you will, actual objective measurements, if you will. Now, again, the other party could argue that, well, the test wasn't completed, and then it gets into how much of the test was completed. Was it enough to actually extrapolate results that appeared to be normal, although the situation is not normal, that these cardiopulmonary exercise stress testing various measurements were. So hence the patient should be referred for dietary consulting, if you will, perhaps maybe a candidate for bariatric surgery, or other form of weight loss surgery, in some form of, again, exercise testing, just exercise regimen, if you will, in order to help the weight loss, etc. And it may be, I don't want to sound too pejorative here, but it may also be appropriate for this individual to get, some sort of psychosocial, consult to see if there's something else going on here. Maybe this individual is severely depressed and is eating and has gotten into this bad cycle that perhaps could be broken with the appropriate intervention. Case 3, 61-year-old woman presents to the general internal medicine clinic complaining of dyspnea with mild exertion. She has a 50-pack-year history of smoking. She's referred for pulmonary consult for a further assessment and care planning. The pulmonary practice prescribes a regimen of bronchodilators, smoking cessation, pulmonary function tests, and pulmonary rehabilitation. Okay, so that seems like a reasonable ensemble of recommendations. Let's look at her pulmonary function tests. Okay, again, forced vital capacity, the actual was, if you will, under a liter, no bueno, it's low. Predicted was just over 3 liters, so 29% predicted. Okay, that's significantly reduced. The FEV1 is, if you will, half a liter. The predicted was over 2.5 liters, 19% predicted. So just before we go on anywhere, let's just kind of pause a minute here. And let's take a look. So far, what I'm very concerned about is that the flows are not marginal, because again, percent predicted, that if someone is in the main is between 80 and 120% predicted, that's deemed normal, because we know there's a certain amount of variation. This isn't borderline. This is not like 75% or 70%. This is demonstrably, these flows are demonstrably decreased, strongly suggesting there's an obstructive disorder. But let's take a look at, again, the measurement, the FEV1 to forced vital capacity percentage. Okay, predicted, and I'm well aware there's a little bit of variability, but about 75 to 80%, this is 83, but 75 to 80, 83% should be able to be exhaled, that forced vital capacity in 1 second. Okay, she got 54, okay, percentage. So she's able to exhale just over half, should be more like 3/4, a little more than 3/4. Okay, she can get just over half. Okay, and we know that the FEV1, the forced vital capacity percentage, is not very effort dependent. In other words, it can be very repeatable, a valid measure of flows. So I'm further concerned that the flows are way down. Let's look at some of our volumes and capacities. Again, capacities are just more than one volume. So residual volume, that's that the gas that really cannot be exhaled. It's the actual is 3.83 liters. The predicted is about 1.5 liters. So very, very much so, so air trapping. So 257% of predicted. Total lung capacity, the actual is almost 5 liters, 4.78 liters. The predicted is 4.44. So just a little over, the predicted. The residual volume to total lung capacity is 80. Okay, so the actual is 80 and the predicted is 33. So that residual volume is accounting for a disproportionate amount of that. So we're very concerned because this patient, again, supporting air traffic. And the DLCO, the corrected DLCO, the actual, okay, is 0.75 and the predicted is 24. So this is a huge diffusion defect. So what we have here is we have decreased flows, we have air trapping, and we have a significant, if you will, limitation to diffusing capacity. Patient has evidence of airflow obstruction. As FEV1, forced vital capacity, FEV1 to forced vital capacity are all decreased, demonstrably so. Or flow volume demonstrates the characteristics of a scooped out, okay, scene. So we're just telling you that, if you will, overall scooped out appearance, okay. Also, if you will, demonstrates markedly reduced peak expiratory flows based on the FEV1 of 19% predicted. This would be classified very severe obstructive lung disease. Patient has evidence of air trapping, and if you will, the residual volume is 257% predicted. DLCO is also really decreased, indicating the loss of alveolar capillary surface area for gas exchange, thus suggesting a diagnosis of emphysema. What additional tests could be recommended to determine any functional benefit for her participating pulmonary rehab? And what we're getting at here is we don't necessarily need all the granularity and expense of a cardiopulmonary exercise stress test. The 6-minute walk test for someone like this, providing they can tolerate, because it really sounds like they're pretty ill. So this would be someone you really want to watch with the test very carefully. They may need to sit down there. They may be on the board dyspnea scale that may be, very, very high on that scale. And you want to just, when they get to a particular point, you want to rest them. And that would count towards the 6 minutes. So you can have them sit for a minute and you can continue the test at just less distance that they've actually walked. So you want to actually, consider them for the exercise for the 6-minute walk test as opposed to the cardiopulmonary exercise stress test. So the exercise stress test could also determine such if you will, changes, but it's much more involved, expensive, and could be considered overkill. And it's also highly likely that the patient will not actually be able to tolerate it. Some selected resources are listed here as well. And with that, I want to thank you guys very much for, again, joining us for these case studies. Hopefully you've learned something from both the case studies as well as other presentations that are related to pulmonary function testing, and we hope you guys join us again. Thanks a lot and have a wonderful day.